All right. Good morning, everyone, or good afternoon, depending on where you are. It's still morning here in Denver. How's everyone doing today? I'm so excited to get started here. Let me just get all my screens up and running. There we go. All right. Everybody's able to see everything. Awesome. I'm so excited. For those of you who don't know me, my name is Morgan. I'm a family nurse practitioner. I work in primary care. I also do some other stuff on the side, which is teaching for Archer Review, which is super fun. And then I work on a mobile unit where we do women's health kind of throughout the city. So, pretty cool stuff. Anyways, I wanted to just tell you about some of the things I know most of you have probably heard, but if you haven't, some of the stuff we've got at Archer just to help you feel really confident when sitting for your boards. So we know that it can be a little daunting to understand, like, how do I study for all of this material that I learned over the course of a year and a half for 2 years, depending on your program, sometimes maybe even 3 years. So we want to really make sure that you feel confident, ready for that exam. So we offer these free webinars, which is great. But to go a little bit more in depth and get a full study plan set up, I really, really encourage people to check out this SurePass Pro. If you don't already, if you haven't seen it already, give it a look. It includes things like our Q Bank, our on demand, and then our live review, which we have one coming up here in February, plus mentoring. Mentoring can be things like helping you prep and get ready for your exam and kind of tutoring, or it can be like talking about interviews and jobs and what you should be looking for and feeling really good. And then once you have the job, we can also do mentoring on like case studies. Like if you have some questions about patient management stuff and you don't have great support, which hopefully you do, but if you find yourself without great support, we are here for you. So we also would love to set up time to talk through some of this stuff. The SurePass Pro, we do have other options. So if that seems like too much, it's not what you need, check out our website. We have lots of other things. And then next up is our community. We really want to build a really strong nurse practitioner community. It just helps all of us kind of be able to communicate and keep moving forward as a profession and as students too. So if you are not part of our group, if you are on social media, join our groups and follow us on Instagram and Facebook, and you can click this QR code here to help with that. I start every lecture by saying the same thing. If you see all my lectures, you probably know this, but if I misspeak on anything and you find more like some contradictions of what I'm telling you, please email us so that we can learn as well. We try to stay up to date, but you guys are in school, you're always learning a little bit faster and more than we are. All right. So for today, we are going to really narrow in on asthma. I decided to kind of bring it down from the full respiratory system to something that I find a lot of people need. So, we're going to talk specifically about asthma, about diagnosis. I built in a really cool case study here at the end, and then I have some great board questions that we can answer together and kind of talk through some of that rationale. So, we're going to hit asthma really in depth to make sure you feel really good. Um, and then I love having interaction. I know that's how you learn. It makes it more fun for me, since I'm not just talking to a screen, to know that there's actually humans out there responding. So if you have your phone present, I know we always say keep your phone away. Go ahead and scan this QR code. I'm going to do it as well just to make sure everything is working. Scan the QR code and join our Slido, and I am going to start it. So it should say that nothing's been activated quite yet. And just for a quick practice, um, let me know, where are you joining from? So this is totally anonymous. You can just put in, where are you from today? This is just practicing, making sure it works. And you can see our suit. Okay, we've got somebody from Tampa and Florida, California. I'm gonna do it. I'm from Denver. It's cold here. Lots of snow on the ground, which isn't typical for us. So it usually snows and then melts, but it has stuck around quite a bit this week. We went skiing this weekend and it was like 5 degrees outside. I don't know how my kids managed to stay out the whole day. I only did an hour and a half. I was done. All right, snow coming. Yeah, I bet. That's crazy. Awesome. The Philippines, I love our international crew. Awesome. I'm curious in the Philippines about the nurse practitioner role. I know the nurses out there are just phenomenal. I worked with a lot of Filipino nurses when I was living in Seattle and just really, really strong education. So that's so cool. Curious about what they do for nurse practitioners or what that role looks like. Okay, next question that I have here is what kind of nursing degree do you have? Are you a student? Are you practicing with one of these degrees? Who do we all have with us today? Let's see here. I'm gonna see. Okay, a good mix. Awesome. I'm gonna add myself, just make sure it works. Yep, everything's working. Oh, it's so fun to see where you all are, what all you're doing. All right, so we have some BSNs, some nurse practitioner students, and some current nurse practitioners. So awesome. So hopefully this will be really helpful for a lot of you. Oh, a lot of practicing nurse practitioners. Great. Hopefully this will be like a review of some of those guidelines that maybe have been tough to stay up on if you're actually out in practice, because that can be a bit of a challenge. So great. I'm so glad. Thank you guys for your participation. Keep that website up because once we get to our case studies, we're going to do everything using the Slido app or website or whatever you want to call it. Just so we can answer questions, ask questions. Again, you're anonymous. And then you can use the chat here. And Rachel is our director. She is in the chat and she is able to answer questions. So I'm going to keep kind of trucking through. But if something comes up today, please don't hesitate to just put it in the chat and we will do our best to answer your questions. All right, guys. So we are going to get started just talking about asthma. All right, so just to start everything off, we follow these are our guidelines that we should use most likely in primary care. Okay, if you're working with pediatrics or if you're also working with adult patients, these are the guidelines that I would really encourage you to reach for, to study, maybe have it posted. I have it in my desk on my board behind just the different steps and the treatment steps. So we'll go over it here in a little bit, but write these down and make sure that you have access to these. They should be free online if you are a current student or your employer if you're unable to access these, but they should be pretty much available for you to review and maybe print a copy of the step. All right. For a really very quickly review here, I just wanted to go over our lung sounds. Okay, this is important for our boards exam, but in general, and just remembering what those different sounds mean and what we should start thinking about. This is a little bit nuanced and it does take some time. So I tell my students always it's really important that you listen to people's lungs, even if you have no concern. Sometimes you get behind and you want to skip parts of your physical exam and somebody who's totally healthy, they're just coming in for a physical. Please, please, please don't do that because that is how you learn to find the abnormal. So the more normal, the moment that something does come back abnormal, the more likely you will be in order to pick up that sound. So try to move through those. You don't have to sit, and listen like for minutes and minutes and minutes. But I always say, do listen at least to 6 spots on somebody's lungs. Make sure you don't miss that right middle lobe in order to be able to know when something abnormal is happening. Okay, so these different types of lung sounds have different names. We're going to start with the normal. The normal lung sounds are known as vesicular breath sounds. Okay, that's a soft, low pitched sound and what it's really indicating when we think of these lung sounds is we're thinking about how the air is moving through our lung fields, okay? We want it to move smoothly and clearly, and we want the sound to stay pretty much the same throughout all. It's going to change a little bit, right? You can listen to your own throat and how the lung sounds do change when we're taking deep breaths, but overall, that really soft, low pitch sound is what we're looking for as for our normal. All right, the brash sounds really can indicate something that's not normal and that there's some sort of something causing the airway to be obstructed or just not getting through the way that we normally hear it. So what we think about here is rail. The first step we'll talk about is rails. You've probably heard them also known as crackles. Okay, I still use crackles because the word crackle really helps me understand what it is I'm listening to because that's exactly what it sounds like. We have both fine crackles Or we have, the lower pitched, fine, sorry, we have those fine crackles that we think about, or coarse crackles. And when we're thinking about these crackles, we're really thinking about some sort of clicking or bubbling noises. So I think about, and I don't know if any of you, I don't even, Rice Krispies, they still exist. Okay. Yes. When you pour milk on the Rice Krispies and you hear the crackling of that cereal, that's what we're kind of talking about here. Okay. So that's a bit of that sound. We typically hear them on inspiration. Okay. And what they're telling us is like, there's some sort of impairment throughout the lungs, but likely some sort of fluid. So I think of pneumonia, bronchitis, pulmonary edema, and then some of those chronic conditions like COPD. All right, next up, I think about rhonchi. These are another abnormal breath sound, and it indicates some sort of airflow obstruction as well. These guys have this characteristic low-pitched snoring sound. They're pretty easy to pick up on. When you hear them, you'll know that this is rhonchi because it sounds like somebody's snoring deep in their lungs when you're listening to that sound, okay? Um, we think of this as congestion, mucus obstructing the airway, but we can also hear this on some sort of inflammatory condition, some pneumonia, cystic fibrosis, stuff like that. Wheezing is going to be something we're going to talk about a little bit more today because we are talking about asthma. Asthma has a characteristic wheeze. These are kind of that high pitch sound that signals narrowed airways. Okay, so we have inflammation happening in our bronchioles. And when air passes through something that's narrowed, we get that kind of high pitch sound. So if you've ever been in like a windstorm, that eerie kind of, or on movies where you can hear the wind kind of, it's moving through something really tight, like a tight space at a high frequency or high volume. Um, and that air is being forced through something small, it kind of creates this sound. And that in our bodies would be known as a wheeze. We think of wheezing pretty much always. We think about some sort of asthma or inflammatory condition happening again here. All right. There is a little bit of a caveat here. So when we hear the same high pitched sound up in the neck area, it's the same pathophysiology occurring. We're thinking about some sort of inflammation causing that airway to become smaller. And when we're breathing in and out, we get that same high pitch, but sounds a little bit different from what we hear in the lungs versus what we hear in the neck. And we call it stridor. Um, Again, once you've heard Strider, you have no, in kids, I've heard it as a mom, and it is really can be a little bit scary, and you should definitely start wondering what's going on. But we think of this also in obstruction if somebody had like a foreign body that they have choked on. We also think of smoke inhalation, and what is happening is we are getting some sort of spasm in that airway, in the upper airway here. All right. Swollen tonsils, croup is a super common one. That's when I've heard it in my kiddos. Um, Middle of the night, it'll wake you up from a deep sleep, and can be a little bit scary. As a nurse, is like, okay, we go outside or put your head in the freezer to kind of get it down. But if it's bad enough, you may need something like steroids to help with it. So it depends on your kid and what's going on. All right, and then finally, this guy here, absent or diminished lung sounds. This is a red flag. All right. If we don't hear anything in a lung sound, it's really important that we follow up on that. Sometimes you place things and you're like, okay, take a deep breath. And if people get tired, if you have an older person with COPD or something, and they're just not able to maintain that, you might have to wait just a moment, let them kind of catch their breath if you're doing a lot of lung sound listening, and making sure that indeed you are getting an absent or diminished lung sound here. Because what we think about is that, at this point, for some reason, there's no airflow happening there. It could be we have a lot of fluid, like to the point where we're no longer getting the crackles or the rails. We have completely stopped any ability for the air to come through because fluid buildup is so much. So I think of things like CHF or heart failure when we have some of that um, overload happening and pushing back into our lungs. We also think of pneumonia, but severe. We think of a pneumothorax, like is the lung completely collapsed? Is it there's signs of severe emphysema? Is this, have we gotten to a really advanced level? And then one pro tip is to always ask yourself, do they have lung tissue in this area? Okay. If they've had a lobectomy and they actually don't have any lung tissue in that area because maybe they had a mass that was removed for some reason, then you're not going to hear lung sounds. And that would be something in which you just want to, know your surgical history on your patients before you send them to the ER for this. But otherwise, if you're picking up somebody with diminished lung sounds or absent lung sounds, that's cause for concern, and we should get them to a higher level of care. This is just another table that I like looking at, some other types of descriptions. So that crackles, that wood burning and a fireplace popping. We have the finer coarse, also known as rails, bronchi, that low-pitched snoring sound. Wheezes and stridor both come in at that musical high-pitched sound. One is just being in the neck area versus the others in the lower lung, in the lungs, any part of the lungs. And then our diminished could be really, really quiet. That shallow breathing. And then we think of, why is there no air moving in that part of our lung? All right. So speaking specifically to asthma, put this in the chat because I didn't put this one in the Slido, but what symptoms would you expect? We're thinking of asthma as a part of an obstructive lung disease, right? What would be like the patient historical chief complaint? What would you think about? What might you hear on your exam? Any ideas when you're thinking of somebody with asthma, what are you kind of anticipating here? Like symptom wise? All right. So when I think of asthma, I think of that tightness in the chest, kind of some shortness of breath, the wheezing, hyperresonance, okay? And then a cough, a dry cough. That is a really common complaint. And I just want you to be, if somebody comes in and that's their complaint, asthma should be on your differential along with a lot of other things. But if somebody has a kind of nagging cough, something that you should think about, could it be asthma, especially in little kids or kids in general? All right, so let's talk a little bit about this pathophysiology. When we think of, the a little sliver of our bronchus, we have our bronchial wall edema, inflammation, we can have some mucus and bronchospasms. All of this stuff is going to cause airflow obstruction or airway obstruction, okay? It really impairs our lungs. It impairs the ability of CO2 to get out and oxygen or O2 to get in. And this is what we consider air trapping. Okay. So we can get, these lungs are just not doing what they're supposed to do. Dyspnea, we consider this like a difficulty in getting air in, and it's a sensation. Wheezing and hyperresonance indicate a difficulty getting air out. All right. And expiration becomes really difficult. We start to see air getting trapped in the lungs, they get hyperinflated, and lungs are literally filled because they can't get the air out. All right, try taking a deep breath take a deep breath in on top of a full inhalation. Like if our lungs are already full and we're still trying to breathe in, it's very, very difficult. And this is what we see when we have things like inflammation, mucus buildup, and then a bronchospasm. So those smooth muscles are contracting, really inhibiting the ability for a person to breathe in or out. Okay, we see that in our lung obstruction diseases. All right, so what causes all of this? Well, we have a lot of different things, and every person is going to be different. So it's really important that we help identify triggers because then potentially we can, reverse some exacerbations, days missed at school, severe, presentation of allergies, hospitalization, and even death. So it's really, really important that we take this diagnosis seriously and we start kind of wondering what is going on here. So we have that atopic triad. So that's the asthma, allergies, and atopic dermatitis, also known as eczema. So we know that those three A's kind of all come together in this person to present with some sort of autoimmune type presentation that increases their risk. So if they have allergies, if they have eczema, they're at an increased risk for asthma as well. So those, I just think of those three kind of in that personality, not personality, I should say persona, just in a patient kind of presentation, they oftentimes go together. We can have medications that cause some sort of inflammatory issues. So beta blockers, aspirin sensitivities can help it. Infections, usually like a viral upper respiratory infection, can be really triggering. We also think of, going out today, somebody with asthma going outside when it's like 9 degrees outside, that cold air can also cause that bronchospasm or some sort of really, really quick reaction. And then, as you all know, we have a lot of folks who have what we would consider exercise or physical activity induced asthma. And with that, what we're really considering is we kind of can predict it. It's like before, when I go for a run or if I go to play basketball or something like that, just get this really tightening in my chest. Doesn't really happen any other time and it seems to kind of go away, but it might have a little cough and it feels pretty uncomfortable when it does occur. All right. So, how do we go about diagnosing this? All right. First and foremost, we're going to ask ourselves, is our patient stable? If we're thinking that our patient is in a current asthma exacerbation, we need to understand, where are we on the spectrum? Is this patient appropriate for primary care? All right. You will see, and I have seen patients come into primary care in an asthma exacerbation. We kind of get them in same day. And yes, we can treat them in the primary care setting, but I am making sure that their vital signs are fairly stable. Their heart rate might be up a little bit. Their oxygen might be, in the like low 90s. They have some of that wheezing going on. I can see that they're kind of, trying to breathe, but maybe not having those uh, muscles assisting. So we're not seeing anything like retractions, the tripod breathing. And if we were thinking this person is in respiratory distress, they're going to be advanced to an acute care center right away. All right. We would consider like chest X-ray, ECG, blood gases, and just a full workup because this can be pretty concerning. This is with somebody with a known diagnosis. We can go ahead and do a little bit of short acting, um, and just kind of watch them improve and consider giving some corticosteroids to help as they go home. So depending on their presentation, those are our options, but really making sure that they are stable and they don't need to be transferred out. All right. So these spirometry, pulmonary function tests, this is something that we just kind of, I like to say with spirometry, we could have an entire lecture and you should in your program have an entire um, long segment just to go over pulmonary functions and studying the loops and what they all mean. We can't cover all of that today, but I'm going to go over the most basic things here. All right, so pulmonary function test is a great way to kind of work somebody up if they're not super symptomatic today. All right, they're having these things, they have this complaint, they have this chronic cough, they have some chest tightness, maybe you have a little bit of wheeze on them. If you work in a primary care setting that offers something like spirometry, great. If not, then you may need to refer out to somebody who does, like a pulmonology team. Here in Denver, we have National Jewish, which is super, super awesome. They do really great workups. And anybody who I can't seem to get under control, that's where I send a lot of folks. Okay, so our pulmonary function tests, we really think of these guys as measuring like how well are our lungs working, and they assess a lot of things. They assess lung capacity, airflow, and gas exchange. Spirometry is a fairly simple exam, like I said, that we can usually do in our primary care office. It helps us diagnose and differentiate between conditions like asthma, COPD, as well as tracking chronic disease progression over time. So we can get spirometry to assess how well we're doing on maintaining and managing our patients. All right, so our major types of the PFTs are spirometry, and then we do it before and after a broncholator. We also have lung volumes, quantitation of the diffusing capacity of carbon monoxide. There are a lot of things when we talk about PFTs, we are talking about a pulmonology full workup. Okay. When we're talking about spirometry, we're talking about what we can do oftentimes in that primary care setting. So, our spirometry. test really is going, like I said, going to help us kind of understand what's going on. It can give us a baseline. It can help us with our treatment, diagnosis and treatment, and then progression. All right. So when we're interpreting spirometry, we're thinking, is this a restrictive versus obstructive disease? Some patients may present with both. Okay. So important to know, but it can be really useful to know what's going on. And if we can't interpret this, if there's something really strange going on with our patient, then that would be like indication for referring to pulmonology. All right. So when we think about spirometry, our most important terms that we need to know, especially for our boards test, but also just in general when we're treating patients, the first one is the forced vital capacity. This is the forced expiratory volume. It's the maximum volume of exhaled air with the maximally forced effort. All right. So you're going to have your patient do a full inspiration and then a full expiration. And this is the total volume that they can express or exhale. And we write this in liters. All right. In general, if we have a low FVC, we need a little bit more of a further evaluation, probably like full lung function tests going on with pulmonology to really determine if there's some restriction present in that lung. All right. Then we have next up the forced expiratory volume in 1 second. Okay, it's an FEV1. This is how much air is forcefully exhaled in that first second. So you do a full inspiration and blow as hard and as long as you can, right? And we'll get the FVC, but the FEV1 is taken out of that. And it's what's in the first second, you're going to exhale the most amount of air, and then it's going to die down, right? So if you take a deep breath in and then you blow out, and you blow as long and hard as you can. That's your FVC. How much can you get in? How much are you pushing out of your entire lungs? And how much comes out in that very first second with your most force? Typically, you're going to have your patient do at least 3 trials and you're going to take the best one. All right. Then we're going to move on. Okay, so when we're thinking about this, we think of patients with asthma, we see a decline in their FEV1. So they're pushing out less air in that first second as their disease progression is worse. So if they're in an exacerbation, that FEV1 will typically go down. And then when we give them some bronchodilators, it should start coming back up, and that shows a success of our treatment. Okay. Then we have this ratio. This ratio is super important. It's the FEV1. So how much is out in 1 second versus how much they can put out overall, that entire exhalation. So this ratio is really important parameter for really detecting airflow obstruction. So we use this parameter in diseases like asthma and COPD. All right, if patients have evidence of airflow limitation on their baseline spirometry and no prior diagnosis, we're going to do a post-broncholator spirometry to really understand, can we reverse this presentation? And if it is reversible, can we improve their numbers by giving a bronchodilator? We will see that this is considered reversible obstruction, giving us a little bit more idea that it's likely something like an asthma presentation. COPD, however, won't necessarily show too much improvement. They'll show a little bit. So you're going to take into consideration their age, their history, their presentation, their risk factors, all these things to kind of help guide your diagnosis, right? And then we're going to use spirometry as our gold standard to kind of put in our specific diagnosis. All right. We also consider the volume, the flow volume loop. And that again is looking the y-axis versus the x-axis and kind of seeing how their lungs do. And something like a COPD where it takes a long time to get that air out. So their FEV or their FVC is going to look different because it's like breathing through a straw or exhaling through a straw. When we have something like COPD, it is very difficult, and your loop will show COPD oftentimes. Look these up, guys. It is really important to understand and study that a little bit more. All right. So, spirometry, it is our gold standard for diagnosing. Here's just another kind of recap. We have our FVC, that's the entire capacity of exhalation. And then that first second, how much air is getting out in that first second, which we would see a decrease as their symptoms are worse. And then our ratio. Okay. So, how much can they get out in 1 second versus how long it takes to get it all out? That's really differentiating between COPD and asthma. All right. So when we think a little bit of this, we think of our standard here, less than 70%, very concerning. When we do a pre and post test, we want to see an increase of 12% of that FEV1 to tell us that we have something that is reversible. Okay. Depending on their severity, those numbers are going to look different, which I'm going to show you in a second. But then when we do our SABA, when we give them that short-acting beta agonist, we want to see that we can reverse this a little bit, at least 12%. All right, and your readout should indicate that. Okay, so we can classify both on symptoms in history as well as our spirometry. It's really important that we kind of know both of these classifications and they come together to help us understand the severity and our treatment and then our progression and our steps, okay, where we're going to go up or down based on all of these things kind of coming together. We can't always use spirometry, but when we can, here's our numbers. We have intermittent. We have an FEV1 around 80 for both intermittent and mild. Okay. Then we get down to moderate. That's between 60 and 80, and anything less than 60%. So severe, you're going to see this on the GINA. It's kind of these two last categories. So if you ever had somebody with a really poor FEV1, less than 60% of predicted, then we're going to be concerned. And our predicted score is based on age and weight. Okay. So that's when we're putting in how much they weigh. And then it comes up with this calculation. This is what normal lung function should look like. And your patient plots out here. Okay. Hopefully, with a little bit of a SABA, we can improve those ratings. We also consider the symptoms. Okay. So we ask a lot about their overall control and how often they're having symptoms. This is something you can actually give them a form ahead of time. If you have an asthma patient, you can have just a questionnaire that helps you as the clinician. And so, you don't have to necessarily remember to ask all these questions. It's on the questionnaire, and they're saying like, how many symptoms, how many times a week are you having symptoms? And they just kind of rate it and it scores for you. So you could kind of classify based on a handout that you can download off the internet or something, or ask your clinic if they have a copy of something like that to kind of provoke these questions that you need to know in order to classify your patient based on symptomatology. All right, so symptoms less than 2 times per week and awakes at night less than 2 times per month. That is really what we're going to consider as intermittent asthma. Okay, there's no interference with daily activities. Asthma is classified that next up as mild when symptoms are experienced more than 2 times per week, but still not daily, and they may wake up 3 to 4 times per month in the night with symptoms and experience, only mild limitations in their daily activity. Right. Then we step up to moderate asthma. This is classified as a person who wakes up at least 1 time per week with some sort of symptom. All right. They're experiencing some daily interruptions to their activities. And then we go to our next, which is severe asthma. That's when somebody's constantly having symptoms every day and they're waking up. And again, with a severe presentation, their FEV1 would be around that less than 60%. Okay, we can consider controlled versus not controlled using this kind of rule of two. Asthma symptoms are considered controlled if we can get their daytime symptoms less than twice per week, nighttime symptoms less than 2 times per month, and they use a reliever or as needed medication less than 2 times per week. If you have somebody who's using their medication all the time, we don't have good control. And so that's another great history question. How often are you needing your reliever inhaler? Okay, if they're saying I need it like 3 times a day, we need to consider stepping up or understanding how are they using the inhaler? Are they using it correctly? Is it expired medication? Getting into that whole thing and asking about, well, what does it look like when you use your inhaler and stuff like that? Do you use the spacer? All of the above. Um, This person should have no interruption in their daily activities. Their asthma should not hold them back from participating in life. Okay. They don't need oral steroids to stay under control. All right. If they're like, oh, I'm great, but I'm also on 5 milligrams of prednisone every day, we don't consider that good control. We need to consider what else we can do. Um, not well controlled is the opposite. All right. So they're having daytime symptoms more than twice per week, nighttime symptoms more than twice per month. They use the rescue inhaler more than 2 times per week. So if you can remember these, we're going to step up or step down based on where we're at. Okay. We're always going to try to use the least amount of medication to control symptoms and make our patients fall into this controlled area. All right. And if they need lots of oral steroids, we need to consider stepping them up and getting them on some more stronger medications because we are not controlling them well if they're having exacerbations requiring oral course, the doses of oral, sorry, courses of oral steroids more than once per year. All right. We don't want to have that. We need to really talk to our patients about, the effects of steroids long term and stuff like that. All right, treatment options. So these are all of the types of treatments that we have when we think about asthma control. All right, we're going to talk about when we use what and how we step up and down, but I want you to be familiar with these different types of medications and the names that we have, the different classes and what they're doing. So we have our short-acting beta 2 agonist, all right, SABA, SABA. We think of albuterol as probably the most commonly prescribed. When I was in school, this was our first line treatment. We gave everybody albuterol inhalers. We're no longer doing that. I'll talk about it in just a second. But what does the short acting beta agonist do? It relaxes the muscle in the bronchial tubes. It makes it easier to breathe. It has a quick onset, but it doesn't last beyond about 4 hours. Okay, so this is a short acting, quick relief, helpful, but again, not long lasting. LABA, on the other hand, or long-acting beta-2 agonist, same thing, just longer effects, but it takes longer to have the effect. So if you had somebody in an acute exacerbation, a LABA is going to take a little bit longer to take to help with that muscle relaxation. And so if you have somebody in your clinic with an acute exacerbation, an albuterol would be more likely. However, we do use LABAs now as a PRN medication mixed with a corticosteroid. All right, we'll get into that in just a moment. So, again, these guys have effects that last about 12 to 24 hours, but with that, again, that slower onset. All right, then we have our inhaled corticosteroid. Abbreviate this as ICS because typing out inhaled corticosteroid on your computer every time you see an asthma patient is going to take way too long. So ICS is what we use typically to describe this. This is really the hallmark in treatment for asthma. And the reason is that it reverses some of that it reverses and suppresses that inflammation cascade. So we are effectively preventing an asthma exacerbation if we can prevent that inflammatory cascade from happening. All right. And then it also decreases that bronchial wall edema that we talked about, the mucus production or hypersecretion, and it also helps with that bronchospasm. So when we talked about those three main causes, our pathophysiology around asthma, we can think the inhaled corticosteroid is really what's helping. Whereas our beta agonists, yes, they work on one characteristic, which is smooth muscle relaxation. Okay, so the bronchospasm there. Next up, we have our muscarinic antagonists. So we have long-acting LAMAs. These guys, we use these guys a lot in management of COPD, and it's a step up again if we can't get control. These guys really are going to work to dry up that mucus. They, again, do help dilate. They're bronchodilators, and these are our first line in COPD and more of our last line in asthma. Okay, so be comfortable. The tropium, I'm so bad at saying that word, is going to be kind of something you see a lot and you will be prescribing. Then we have montelukast, which something else, that's the leukotriene, very specific allergic causes. We think of this guy, serious mental health side effects on this. So make sure you know that. Montelukast, that black box warning, I think of suicide ideation with this guy. We have seen it. It's in the literature. Make sure that if you're prescribing it, you're having that conversation and telling your patients, reach out, stop the medication, reach out to us as soon as possible if you're experiencing anything like suicide ideation or worsening mental health. Mast cell stabilizers, blocking antihistamines so we can kind of decrease that edema and that mucus secretion and bronchospasms here. And then we can step it up to our IgE antibodies. That's going to reduce cytokine release. So, really blocking that inflammatory cascade, okay? Working at that inflammatory cascade a little bit further down. So, when we think about the medications, think about the pathophysiology and where we are intervening with these different types of medications and how they're helping the patient, okay? So, your pathophysiology around asthma and what do these specific types of medications, how do they help? All right, so our GINA guidelines. I put this in here just to kind of help you also understand our steps. So as they get better, we're doing our step. I mean, I always say step up. It used to go up like this, but now it actually is coming down, but the numbers are getting bigger. So we're still increasing our step numbers, but we are actually going down the steps. But the biggest takeaway from this change that we have here is that we no longer are using a SABA as our first line. This was changed about 5 years ago. And the reason is that we are not treating the inflammation or the mucus, and it actually increase the risk of hospitalization, severe exacerbation, and death. So we're kind of steering clear of that anymore. Um, what we can do, so we would use for intermittent asthma, our step one is an as needed combined inhaled corticosteroid with a long acting beta and agonist. Okay. So it's a LABA plus an ICS, and we use it just as needed. The alternative track here that we could consider is if they're already on that SABA, then we're going to go ahead and tell them, all right, since you're on the SABA, you already have your albuterol inhaler. I'm not going to, make you spend a ton of money on these expensive inhalers. All I'm going to do is add another inhaler. And if you need your SABA, take the SABA with the new prescribed ICS. Okay, the inhaled corticosteroid. And so you're going to take two different inhalers because here it's combined. Now you're going to take two different puffs on two different inhalers with two different functions, and we're really getting at that inflammation, mucus production, as well as the smooth muscle dilation. Okay, quick relief medications for all of the above is the same inhaler. Yay! This is amazing. We don't have to go around with 2, 3 different inhalers in our purse any longer. We literally have the same inhaler for the treatment, and you can see that goes all the way down. So that's pretty exciting. Okay, then we can step up. So say their symptoms are getting a little bit more towards this mild, which is like twice a month or more, but less than daily. Doesn't really specify, but we could go back and look at our nighttime awakenings, not too much. All right. We could do again just the PRN, excuse me, the same thing that we did up here. The alternative would go ahead and do again these two, or that daily that sorry, what the leukotriene receptor antagonist. But again, I'm going to stick more to track one with most of my patients. All right, at moderate asthma, step 3. These guys are having most days waking up with asthma one time a week or more. Okay, so now we're getting up to step 3. This is where we're going to prescribe every day. All right, they're having enough symptoms that we need to consider a daily dose of this stuff. All right, intermittent mild, we're still on an as needed basis. And then our rescue inhaler or quick relief inhaler is the same. And same over here, our quick relief inhaler is going to be the same that we're doing every day. So we're going to carry that along. Step 2, you could increase the amount of the inhaled corticosteroid. Go ahead and look at your charts on like UpToDate or wherever you find your medication information to understand low dose, medium dose, high dose of your inhaled corticosteroids, because that's what you're going to be prescribing. Plus, plus a LABA. So now you have two inhalers, kind of like what we saw up here. But you're always prescribing an inhaled corticosteroid. Okay. That's what's new here. Then we increase to our severe symptoms. We're going to increase. And here I'm really thinking about pulmonology, guys. I feel really good managing between intermittent and mild and moderate, and I can manage these guys. If we're getting to a lot, we may increase and go to a high dose or something like that, medium dose, and see how they do. But I'm seeing this patient back really soon, and keeping a really close eye. If their FEVC and FEV1 are really low, then I'm considering maybe doing something else. And they're not reversible, and I'm having trouble. And this person's having a lot of resistance kind of to my step ups. I'm considering around these areas to refer to Pulm for a little bit of help. Um, Okay, and you can just see we're just increasing the dose of the inhaled corticosteroid, considering adding on. Here's where our llama comes in place here. Remember, we used that right away in COPD. We're going to use it later here. Okay, now we have our pediatric considerations. The really only big difference here is in step one. So the severity is going to be very, very similar. In step one, our rather than just jumping right in, let me go back to this dual medication. Our step one here is that they have two inhalers. Okay. Um, so they do the two different inhalers every time they take the short acting. Whereas here we had that long acting inhaler, or we could do what they're doing in pediatrics. All right. I'm just going to tell you as you're going down the steps, again, I'm really comfortable managing steps 1 through 3. Maybe step 4, but if we're getting, if these kiddos are really resistant, severe cases, we have pulmonology help us. Okay. Kiddos are really at risk for severe complications from asthma. You may have heard or know somebody who has died of asthma, and it is a serious thing. I just read about an article of a kiddo not too long ago, now that we're getting into flu and sick season. So just something to really know. If the kiddo is not responding the way you're hoping for, and you've kind of done all your troubleshoot, you're seeing these kids pretty frequently, not going more than a few 5 days without seeing them if they're stepping up. But making sure that we're educating parents really, really good on how to use the inhalers and stuff. All right, then we have our other the National Heart Lung guys. All right, Gina, it's usually what I use, but these guys also updated their guidelines as of 2020. And both guidelines really recommend that combined ICS with the long acting or for Metrol for the first line treatment options. But this guide goes one step further and states that we can use a short acting first line treatment, but only in all ages, but only for that really, really like intermittent asthma. So like if they have a flare, maybe 2 weeks out of the year when the trees are in bloom, this guideline can come into play for that patient. Okay. But it also wouldn't be wrong for that patient to go ahead and just have them on something like the ICS combined with this. All right. So that's just one other thing. The SMART therapy or MART therapy, I like this guy. All it is saying that you're using the same inhaler for both rescue and maintenance, which we saw in our GINA guidelines, right? We saw that back here. Oops, sorry. We saw that back here where we use the same thing. And I just love that. It makes life so much easier. They have this at school. It's easy at home. It's easy at the soccer fields or wherever. It's just easy. So that is that SMART inhaler. It reduces severe exacerbations. And that's why we have chosen this. And I prefer this as the way that I'm doing with most of my patients. I'm kind of staying away from that SABA use or the albuterol use. I use it occasionally if somebody has like some URI symptoms or something like that. But for my asthma maintenance, I am definitely getting on board with this more GINA, the GINA guidelines, and just trying this. Most important thing when we're including around patient education when we're doing something like an inhaled corticosteroid is making sure that you are educating the patient to rinse their mouth after they do their albuterol or their inhaled corticosteroid. Does anybody know why we want to rinse our mouth out? What am I concerned about? Any ideas? So what I tell my patients is if I have you on a daily regimen, it's harder for people who are on that as needed. But if you're on a daily regimen, I suggest having your inhaler just next to your toothbrush and toothpaste, and you go ahead, do your inhaler, and then you follow up with a good mouthwash, brush your teeth, and that should be plenty. And the reason being is that we want to prevent something like thrush, oral thrush, or that candida in the mouth because when we give stuff like corticosteroids, we can be at a higher risk of thrush. So go ahead, educate them around that. All right, this is just another quick look at some of our offerings that we have. We have about 12, 13 minutes for our case studies, which I'm super excited about. But again, if there's something I misspoke on, make sure you take down this email. You can, or if you have any feedback, I love feedback. It's how we get better at this. And then if you haven't already scanned this QR code, these two QR codes, you can save them in your phone for another time when you have a moment to kind of explore them a little bit further. But if you don't have any questions, I'm going to jump right into our case study, and then I have some board questions. If you have a moment to hang around, please, please, please do so. I think it's beneficial. Okay. Um, so pull your phones back out. And I want you, if you kind of got out of this, you can just rescan this QR code. I'm doing it with you. Okay, rescan your QR code. And I'm gonna come over here. Sorry, I just had to look at that all the entire time. Okay, and this is who we had, lots of nurse practitioners and students. Okay, um, the first question, I'm going to just present our case study, but what I want you to be thinking about, and I want you to be typing in here, as you hear this case study, I want you to think about what are your initial thoughts or questions on this case? What are your differential diagnoses? What is coming to your mind as you're hearing me read this case study? Again, no wrong answers. Okay, I wish I could show you. I wonder if I can do this. Okay, I'm gonna see if I can. Oops, show you both things at once here. Sorry, bear with me. I'm not like great at technology. Okay. Um, Let me see what you can see here. Awesome, you can see both things. Okay. All right. So our case study here, guys, we have Samantha Jones. It's my cousin's name. I just grabbed it. 15-year-old, she's not 15, student, female, history of allergies, eczema, secondhand smoke exposure in the home, family history. Mother has asthma. Okay. Her HPI, she tells you she has episodic once a week, no nighttime awakenings. Maybe she filled out that report for you. Great. But reports cough, wheeze, shortness of breath. It's been kind of going on more than 6 months, but it's just getting worse. Worse typically at night, early in the morning. She's reporting some chest tightness. Let's say she just recently joined the dance team at high school, and when she notices when she's dancing that it's just really uncomfortable, just a big kind of shortness of breath, chest tightness happening. Denies any other systemic symptoms, so no URI or anything like that going on. All right. Your physical exam, you have in her lungs some scattered expiratory wheezes. There's no crackles or stridor. Her nasal mucosa is kind of pale. There's a little bit of postnasal drip. And then you go ahead and order a bronchodilator test. Okay. Any initial thoughts as we are reading through this? What are you thinking about? Is there anything sticking out to you when you heard the history of allergies and eczema or her smoke exposure? What are you kind of thinking about? And put that in the hole here. And it's just a free write, so you can write anything you want. But I just want to start hearing maybe some differential diagnosis. What could be going on, kind of listening to this? Um, Any sort of initial initial thoughts as we're moving through this case? Okay, yeah. What else? Great. Asthma due to history, absolutely. What kind of things are you thinking about? Intermittent asthma, I like it. Okay, you're thinking about that already. And then I'm gonna get anything else, just kind of keep blurting them out. Other concerns, workups that you might consider, just like what's going through your mind. All right. Keep putting them in the chat as you hear more of this case study, okay? And this is just like your what thoughts are happening in your mind right now. All right, so we're gonna do the spirometry. We're thinking, she's had this cough, she's reporting some chest tightness. We're all thinking it could be asthma. Um, Nobody's had any other differentials. Let's see here, what else would I think about? Mean, it is pretty much asthma, I guess, the way I wrote it. And I gave you a lot of clues here, but um, maybe a URI, maybe some sort, but 6 months, the time frame doesn't really work for anything acute, right? Pneumonia, good. Yeah. See, that's kind of what I want you to think about, just making sure you're asking these questions to get those differentials off your mind. But she gave us all this really good information. Anyways, okay. Uh, Pre-bronchodilators spirometry, our FEV1 was 75% of predicted, and then our ratio was 0.68. Okay. Then we gave her a bronchodilator. We waited 15 minutes, and we went ahead and retested, and wow, she improved. All right. She improved 15% and over 250 mils. So that's great. And we see that FEVC ratio come up. She's at that 0.74. All right. So my next question here, and you can continue to write it here, is how would you classify her her asthma? What medications would you consider? And any like um, patient education, prevention, things that we should talk with her about. Okay. So when we look, we have, if you guys remember this, we had this kind of, we can diagnose her. So she's kind of like leaning in towards this. So kind of mild, moderate based on that. And then we think about symptom severity. Oh, I like it. Yeah. Okay. We could go that route. Okay. So then we have her intermittent. So she's having less than two per week, wakes less than two per month. So based on our symptom control, and this is kind of what I want you to think about, that we don't just use one number, we're kind of using both things to put her in her classification. More than two times per week. So she told us, one second, she told us that she was having symptoms once a week. Okay. No nighttime awakening. So we can consider based on that less than twice per week. So based on her symptomatology, she kind of classifies here as like intermittent. Yeah. All right. And then look at our guidelines. So some of you said an ICS and a short acting, which would not be incorrect. That would be following that track too. And what is the other one? What is our first line treatment for this? Got it right here for you. And so the formoterol is not short acting, remember? That is our long acting. And that's our big difference. Okay, awesome. Okay, so what we're going to consider here is again, going ahead and prescribing her this. If she already had a short acting, then we could just add an inhaled corticosteroid to that. So that wouldn't have been incorrect. All right, but we're thinking about things a little different. Okay, so just a little brief replay here. This is now a boards question. I'm turning this into a boards question for you guys. So this whole scenario. Okay. So this is our 24-year-old. sorry, 15-year-old, whoops, with a 6-month history of intermittent wheezing, cough, and shortness of breath, primarily at night and during physical activity. She reports no smoking history, but lives with a smoker. She has a history of eczema and seasonal allergies. Physical exam reveals that expiratory wheeze, and spirometry shows the following. This is what we just saw. Okay. Improves to 88%. This is the key, I think, that maybe some of you guys got hung up on a little bit. So we did see that huge improvement. She's above 88%. Okay, based on this patient's presentation and diagnostic findings, which of the following is the most appropriate initial step in her management according to the Global Initiative for Asthma Guidelines, or the GINA guidelines? All right, and you guys can read your answers and go ahead and tell me what you're thinking here. Awesome. C is what I have here. One person said C. Anybody else? You can scan your QR code. Maybe if I went back to her presentation, is this helpful? All right, we've got 2 people who said C. Awesome. All right. The correct answer is C. So really good job. We are the rationale here. So based on the patient's symptoms, history, and spirometry. So remember, we take them all kind of into consideration. The GINA guidelines, first line of treatment is that ICS and formoterol for symptomatic control and reduction in exacerbation in mild or intermittent asthma. We consider option A, SABA-only therapy, no longer recommended due to an increased risk of exacerbations without addressing that airway inflammation. Remember, the SABA does nothing for our airway inflammation or for our mucus production. And option B, that daily ICS with as-needed SABA. This is an alternative. It's less convenient, so we wouldn't go that way. And then option D is unnecessary as the diagnosis is clear with spirometry and clinical use. Okay. We can treat this person in our clinic. Okay, and then again, our treatments for this case study, first line therapy, that low dose inhaled corticosteroid formoterol as needed for symptom relief and prevention. Alternative would be, and somebody said this, that daily dose ICS with a as needed SABA. And then patient education, proper technique, treatment, adherence, and ongoing monitoring. Okay, I've got another question. Do you guys have a moment here to keep going? Got 1 more minute. We can get through this one. Okay, so we have a 30-year-old patient that presents with an acute exacerbation of asthma. Okay, so we already know they have asthma. Now they're in an exacerbation. Exam findings includes pulse of 100 beats per minute, respirations 22 per minute, oxygen sat 93, not using any of those accessory muscles. So we don't have any of the, retractions or anything like that, or nasal flaring, no distress, lung filled with wheezing, and noted dry cough throughout your assessment. Which of the following is appropriate management of this patient? So we know that this person, he or she, I guess we don't know, it's not specified, is having an asthma exacerbation. What do you consider? Okay, let me pull this up over here. Oops, did I go too far? Oh, yep. Okay, this one here. All right, what do you think is the answer, guys? Might be losing some people here. All right. Okay, so an albuterol inhaler. All right, when we're in an exacerbation, do you remember another thing that we talked about we could consider using? That is correct. Oh, and some people are answering in the chat. Awesome, guys. You probably on your phones. Can't do both. Okay, so we had 2 people answer that. The actual correct answer, so this is boards. The safest thing that we need to really address is that airway inflammation during an exacerbation. The smooth muscle and giving that short-acting inhaler is absolutely something you should do. But along with that is getting that initial corticosteroid on board. Okay, quickly and moderate. And we would go ahead and do an albuterol inhaler in clinic. I would do both of those things. So not wrong, but what I really want you to think about is considering the safest is decreasing that inflammation. And so if you're thinking about asthma, always think about that inflammatory condition, and we need to get that inflammation down quickly. The Saba is going to be something great. And if we did that standalone, awesome. I kind of wish that this question were to say initiate prednisolone, the Aura pred, as well as a Saba. And that would have kind of given you the answer. So this is a tough question, I'm going to say, and I don't love. I mean, it's the first time I've used it with you with the presentation, so I get it. Okay, well, we had one more practice question. If you all have a minute, you can hang around. Otherwise, it's been a pleasure. Please join us. We have lots more free webinars coming up, but click on our link, see if there's anything that interests you. Okay, there's one more question here. This is really talking about how to utilize that properly. I'll let you just read it. All right, we got one person who's answered. Anybody else want to give it a go? Awesome, and I see your responses in the chat as well. Awesome. All right, guys. So, um, B is absolutely correct. So what they're doing is they're inhaling and exhaling very quickly, and just repeating for the next dose. So that is actually not the way that we want to take an inhaler. And here's your rationale. Um, Inhaled slow and deep breaths. So that quick thing, not great. And hold your breath for about 10 seconds in between. And so this one initially, I kind of thought when I read this question, place the powder dose inhaler in the mouthpiece and mouth and breathe in hard and fast. And because it's a powdered dose inhaler, that's exactly what you're supposed to do. It took me a minute when I heard hard and fast, but it's this kind of action that you have to do in order to get that powder to come in. And so that's a consideration when you're prescribing it. Is there enough coordination from your patient to be able to do that versus the one that can just be kind of pressed into the mouth? So you got to think about all of the context of what you're asking your patient to do and making sure they're capable of doing it. Once I prescribe these, I often do a follow-up and have them come back in with their medication, and we do that a dose together. So I tell them, hey, why don't you pick up your medicine? I want to check and see how you're doing, and I'm going to schedule you for an early morning appointment. You'll be my first patient, and I want to see how you're actually using your inhaler to make sure you're doing it correctly. So I'll bring them back in, 5 days later, whatever we think it will take them to pick it up. And I'll also see like some sort of improvement a little bit, but also just a quick follow-up. But bring your medication, don't take your morning dose until you do it with me. And then of course, if there's an inhaled corticosteroid, I am going to send those folks to the bathroom to do a little swish and spit to prevent something like an oral thrush from developing from the use of inhaled corticosteroids. All right, you guys, it's been such a pleasure. I look forward to seeing you in February. Hope everybody has a wonderful rest of your day and your week, and good luck no matter where you are in your journey. I wish you the very, very best. Always a pleasure. Take care, and we will see you soon with our jury review. All right, take care. Bye bye.